Hello and welcome to today's webinar, Clinical Congress Tips and Tricks to Proposal Writing. My name is Jessie Von Custer. I'm the Program Administrator for the International Relations Committee. This webinar was pre-recorded and will be available on our YouTube playlist under the Global Surgery Webinars. I'm pleased to introduce you to today's moderator, Dr. Bassem Safadi. Dr. Safadi is the Chair of Surgical Services at Amman Hospital in Doha, Qatar. He specializes in upper GI and bariatric surgery. He's a member of the International Relations Committee and is the Vice Chair to the IRC Program Subcommittee. Dr. Safadi is a well-known figure in surgery in Lebanon and the Middle East. He's joined today by our esteemed panel, Dr. Christy Chai, Dr. Kenneth Sharp. With that, I'm going to now turn it over to Dr. Safadi. Dr. Safadi.
Thank you very much and welcome to this webinar. First, I would like to introduce Dr. Christy Chai. Dr. Christy Chai is an Associate Professor of Surgery at Baylor College of Medicine in Houston, Texas. As former Air Force surgeon, she continues to serve veterans as Chief of General Surgery and Surgical Oncology and Deputy Executive of Operative Care at the Michael E. DeBakey VA Medical Center. As a dedicated educator, mentor, and surgical leader, Dr. Chai actively contributes to multiple surgical societies. She currently serves as the chair of the IRC's Program Subcommittee and is committed to fostering greater engagement, transparency, and guidance for international members in the Clinical Congress proposal process. Secondly, I welcome Dr. Kenneth Sharp. Dr. Sharp joined the faculty at Vanderbilt University School of Medicine in 1984 as an assistant professor of surgery and is currently professor of surgery and vice chair of the section of surgical sciences for faculty promotion and development. Dr. Sharp has published several book chapters and over 100 papers on topics spanning the broad field of general surgery, including minimally invasive surgery, GI surgery, trauma, surgical education, and oncology. After participating in various ACS leadership roles, including being the Tennessee chapter president and serving on the board of the ACS Foundation, Dr. Sharp was elected to the American College of Surgeons Board of Regents in 2018. As a regent, he serves on the Communications Committee and is the chair of the Member Services Liaison Committee and Nominating Committee. Dr. Sharp is also the chair of the ACS Programs Committee. Thank you all for joining us today. With that, we will turn it over to Dr. Sharp to begin his presentation. Dr. Sharp.
Thank you. Thank you. I would just like to first show just a very few slides that I use in talking to the Board of Governors work groups, to the Advisory Council program liaisons, and a number of other groups. So let me share my slides. I promise not to be too terribly long on this. Okay, in terms of how we structure the clinical part of the Clinical Congress, I'm not going to talk about scientific forum or the video-based education sessions. And just a little bit of historical data, we get somewhere in the neighborhood of 300 and some odd proposals for the Clinical Congress panel sessions every year, and we accept about 100. We break those down into roughly 70% clinical and 30% non-clinical. And these numbers change up and down just a little bit. We usually have somewhere in the neighborhood of 10 to 12 didactic courses, 8 to 10 surgical skills courses, and we have 15 meet the expert sessions every day. So for a total of 45. The town halls are going away. Those were the early morning non-CME events that really, unfortunately, just drew. They were a dying breed, and we're not getting very much attendance anymore. The way that we break down the clinical program, and this is in the clinical sessions, obviously not the non-clinical, is we take around 70 clinical papers and we break them down very roughly with this breakdown. About 80% of the people who attend Clinical Congress are general surgeons. So we heavily weight this towards practicing general surgeons as far as the breakdown. But we do have gynecology, head and neck, GU, occasionally a little bit of ortho, and ophthalmology. So we do try to cover a broad field of general surgery with a little bit of the specialties blended in. The non-clinical sessions are broken down by these pillars: advocacy and health policy, inclusive excellence, education, ethics, history, innovation, professionalism, quality research and optimal patient care, and surgical career issues. And you can see we've had as few as 30 and as many as 40 non-clinical sessions over the last several years. I didn't go back any further because during COVID, we had virtual meetings and things were different. As far as how you develop the clinical program and the non-clinical program, we have a clinical taxonomy, which is organ-based, and we have a non-clinical taxonomy that's based on those pillars that you saw on the last slide. We are trying to cover the broad field of general surgery roughly every 3 years. It doesn't exactly fit to that, but just as the example I always give is that we have a lot of need to cover colon cancer every year, but carcinoma of the appendix is a little bit of a niche area. And so we really don't want topics on carcinoma of the appendix every year. That's one of our quote unquote every 3-year topics. So as we look at the taxonomy is a Q1, a Q2, and a Q3 year presentation cycle for some of the topics. And so we are going to discourage, if we had, for example, if we have a topic on carcinoma of the appendix for 2025 Clinical Congress, it's unlikely we're going to want one for 2026 unless you have some breakthrough information or practice changing information. And so when you submit your session proposal, you'd need to tell us why would it be important to have this presented 2 years in a row. The taxonomy will be shared with all of the applicants as they make their proposals. The proposal site will open approximately April 1 and be open approximately 6 to 8 weeks. So improving your acceptance rate. Look at the taxonomy topics that we're looking for the current year. If you see that that topic was presented the year before, make sure you don't represent the same thing. I know there have been several popular topics, but honestly, if you want to present abdominal wall reconstruction every year, you better give it a different description and a different title. We are very much interested in multidisciplinary sessions. So one of my favorite examples here is that if we have a session on the mangled extremity, we're looking to include trauma surgeons, general surgeons, plastic surgeons, vascular surgeons, and orthopedic surgeons. So if you have a multidisciplinary topic, that's a really good thing to submit. You will need to work with the other societies, and that gets to be a little bit difficult. And be sure to reach out to the program committee and the ACS staff. We have a fabulous staff who can help answer your questions about your proposal and how to answer it. And that's the last of my questions of my slides. So just a general overview of how to work with your sessions and proposals.
Great, thank you, Dr. Sharp. And so I'm gonna start asking you some questions for clarification. So one of the first questions is, why should someone submit a session proposal to the Clinical Congress? Kind of a broad question.
I can start with that question because, I think writing for proposal and getting it through and see it through as a session, it teaches you a lot about how ACS works and all the works that goes into to create a session. If you don't have the experience, of course, American College of Surgeons Clinical Congress is a great meeting, but I think writing a proposal and seeing it through really gives you an opportunity for several reasons. Again, you learn how you learn to be a actively contributing member for sure. And then, and you get to network with other members, asking them about becoming a co-moderator or reaching out to them about inviting them as a panelist or speaker. So it's a great opportunity to network. And, maybe even if they're not member of ACS, it's an opportunity to network with experts in the field. Also, as a junior and mid-career surgeon, I think it's an opportunity for you to educate and inspire other surgeons, and a way to advance and grow you in your own profession. So it was a great opportunity for me once I got it started.
Yeah,
I would just add that you do need to be a fellow to be a
Yes,
moderator, a co-moderator, or a
right.
speaker. You can be an
Oh,
associate. You can be an associate, but we don't normally let non-ACS folks present. We've made some occasional
yes,
exceptions for somebody who needs a radiologist or who needs
yes.
a
Medical
oncologist,
oncologist. Yes, that's right. You're right. Thanks
but
for correcting that.
it's not generally for residents or fellows by and large. It's for members of the American College of Surgeons who are not in training anymore.
Right.
But I think that I think oftentimes we have people who really have a intense interest in a subject, and they believe they can educate other people who are attending Congress in an important area. So I think most people feel like, I've got something that I think I know pretty well, and I'd like to, disseminate my knowledge and improve the practice of the people who are attending.
Yes, I really do think it's a fulfilling experience to be part of, making a clinical congress a successful one.
Great. So let's say I decide I want to submit a proposal. This is my first time. Do you have any tips on where to begin the proposal writing process? Any tips?
Go ahead, Christy.
Well, I was going to say Dr. Trout probably gets a lot more advice,
Okay.
but for me though, I do want to say, like, starting the proposal is half the battle, because sometimes you kind of feel small and you feel like your idea is not important. So I think sometimes people don't even try, right? Because there are so many experts, there are so many great members in ACS. Like, who am I to write this proposal? But I think one of the tips is be confident. I can tell you the proposals that I submitted that got accepted, they weren't really earth-shattering, but I think people thought that it was applicable to a wide range of audience.
I think this maybe is a little bit of a nuts and bolts question. And so the submission for proposals for the panel sessions will open April 1st, and it will go to all of the people who are eligible to, and we don't send it to every fellow. I will tell you that we send this request to the advisory councils. We have 14 advisory councils. There's something around 30 or 40 work groups within the Board of Governors, and there are over 100 committees and subcommittees within the American College of Surgeons that submit information to us that they want to submit a proposal. So it is very competitive, but working with your advisory committee or your committee, your governor work group, there will generally be somebody who has done it if you haven't, and they can guide you through the process. But there'll be there's a website that will open up. You'll have to, sign in with your member number and do all the ACCME requirements. And then you'll put in your proposal, which is really, you only need 3 to 5 sentences to describe what you want to talk about. And I always tell people, you want to tell them what your topic is, what your talk is about, and why it's important, and who is it aimed for. That's 4 sentences. Okay, so you don't need you don't want to put a half a page description of your session. You will need to know who you're thinking about to be the moderator and the co-moderator. And we ask for an alternate moderator and an alternate co-moderator, because we have a surprising number of people who drop out or have conflicts. And again, for equity, we want a diversity in the moderators and co-moderators, and we want alternates, so that if we do not let one of the fellows moderate or co-moderate more than one panel session. We want to spread the wealth. So we need all 4 of those names. Those people do not need to be notified to begin with, because we hate for people to be notified, oh, I'm putting you in as a moderator on panel X. And then that doesn't get selected by the program committee. And certainly we don't want people looking ahead and going ahead and notifying speakers. We do not need the topics for the various talks within the panel session.
You know, the other thing I also want to point out is just like Dr. Sharp said, we have fantastic staff and we keep all our old proposals. And I know some of our proposals get feedback and we've resubmitted them next year. And we've gotten those accepted as well. So just because you wrote something and didn't get accepted this year doesn't mean you can't, you know, make some corrections, make some changes and resubmit, because those have been accepted as well. And, you know, our staff will definitely share the ones that was accepted as well as non-accepted one with feedback.
So going back to the moderator, Dr. Sharp, you mentioned that they have to be fellows, right?
Yes.
And so what makes a good moderator if I want to, you know, identify and pick someone?
Well, a good moderator, number one, can speak comfortably in public and has to be pretty much a topic master. You can't have somebody, you know, you wouldn't want me to talk about mangled extremities. And I think the other thing that's important that for a moderator is to have a knowledge of the people who are active in the field, so that you ask appropriate people to give talks that you think will be appropriate and pertinent to your topic. So I think a moderator has to be able to, and need to be able to control time. We cannot run over in our sessions. We have 90 minutes and we can't run over because we have another session starting right afterwards. And so you have to be able to handle people. You have to be able to handle questions from the audience. But most importantly, intense knowledge of the subject and others who have information and knowledge in areas that you want spoken upon.
Great points.
And one other thing that I want to point out about moderator is that, as mentioned previously, if you list people, we need to have multiple people listed because not everyone will say yes to invitation. And so, yes, you do have to have interest in some expertise and interest in the topic, and don't be shy about putting yourself as a moderator if you're writing a proposal and it is your field of interest, and if you're in that field, because you wrote the proposal, you know the goals and aims of the session the best, you have the expertise in that session. And when I say expertise, you don't have to be the world's expert in that topic, but if it is a relevant topic to you, because if you put yourself as a moderator, you're more likely to see it through, right? Than you're being invited for somebody else's idea. So don't be shy about putting yourself as a moderator.
A very good point, Christy. I have a question on Meet the Experts format. Like, you know, what makes it different from the other panel sessions, and you know, how do I plan a successful Meet the Experts session?
Well, first, it's singular, Meet the Expert. So the Meet the Expert sessions are 1 hour sessions in the middle of the day. These used to be, in the old days, a lunch session with these expert. Unfortunately, the convention centers are now charging $75 for a box lunch that has a stale sandwich, an apple, and a Coca-Cola. So we dropped the lunch, but they are limited in attendance, no more than 30 to 35 people per room. So we do charge a small amount for attendance in order to make sure that people show up for these limited attendance events. We develop the Meet the Expert sessions in several ways. Number one, we have some of the sessions are so successful that we meet every year. I will give you an example for Dr. Fabrizio Michelazzi from New York. He's an acknowledged international expert on inflammatory bowel disease, and his session on Bring Your Toughest Cases is generally fully subscribed every year. David Feliciano could fill a room in a heartbeat when he would talk about any trauma topic. So it's nice to have a recognized name, but that's not essential. But you want somebody who has focused expertise on something they want to talk about. These sessions are, like I say, they're an hour. There's no AV and there's no CME. But it's a chance for people to explore the knowledge of an expert in an area. And so it's often very popular. People will bring along their own cases that they're dealing with at home to ask somebody for a curbside consult on.
And the other thing is, if you're writing a proposal for the expert session, it may be nice for you to suggest the expert. And if you can reach out to them, I can tell you last year, we had meet the expert session for burn specialty that was accepted. But the person that was named as the expert, we could never get hold of. So unfortunately, that session was canceled. So obviously that happens, but all these program committee puts a lot of time and effort to come up with the full schedule. So if you're doing meet the expert session, it would be nice if you could somehow get partial confirmation that they would accept once accepted.
Yeah, that's a very good point. So Dr. Sharp, you mentioned there are clinical session proposals and non-clinical session proposals, and the clinical session proposals are based mostly on organs, correct?
Correct. We do have, I mean, for example, critical care. We don't have critical care, by organ systems. It works out pretty well because, for example, let me just use GI as a very popular topic area. So we have in our taxonomy, under GI, we have bariatric topics. We have stomach cancer, ulcer disease, gastrointestinal bleeding. Under colon, we've got colon cancer, colitis, and so forth. And obviously cancer in all of the various organs is its own subtopic. I think that the important thing here is that we do have acknowledged that, for example, we had several years ago, we had people who were presenting a session on some new chemoradiation therapy, and it was gastric cancer and colon cancer. It was really rectal, okay? But that didn't, which organ system do you put that one in? So we do have some broad oncology topics for multidisciplinary therapy, et cetera. So there's no perfect way to organize a topic list for, all of surgery.
I can imagine it's very difficult, and also choosing the taxonomy, I'm pretty sure sometimes can be difficult. So do you have any tips on, choosing the taxonomy? You mentioned one is to make sure that it wasn't listed on prior, or let's say the year before or something like that.
Well, again, I think, you go into a proposal thinking about, I would sure like to talk about new developments in the treatment of inflammatory breast cancer. We don't really go to it by saying, I want to talk about breast. I'll look at the taxonomy. I think most people think about, what do I want to talk about and where does that fit in the taxonomy, rather than vice versa. So I think, if you want, we have, for example, benign breast disease every 3 years. Well, if you want to talk about benign breast disease, which is a field that is changing, you don't really go into the breast taxonomy and say, well, let's see, I've got benign breast, I've got DCIS, I've got screening, I've got cancer, et cetera. I just think people mostly look at what do they want to talk about and where does it fit. I mean, that could be dodging the topic, but I think that's how most people think.
Dr. Safadi, just going back to real quick about moderators and meet the experts from International Relations Committee standpoint, some of the experts that we invite are from overseas, kind of traveling quite far. And I just want to make sure it's still the same, Dr. Sharp, that we do not pay for travel for these speakers, correct? And panelists when we invite them?
No.
So,
moderators, speakers, panelists, not only do we not pay for their travel or housing, they have to register for the meeting as well.
Yeah, so that's something to keep in mind when you list international members as the moderators, experts, because they need to be able to travel and pay for the meeting.
Yeah, and to set their expectations as well. Yes, yeah. Have you noticed any patterns on what makes a session successful?
You know, in reality, I think at least the times that I've attended, I think clinically related, more relevant topics tend to have more audience. You know, general surgery topics, uh, and then some of the hot topics, like I feel like every meeting, every societies now are talking about AIs and these new innovations and things like that. So I think what interests the people will, you know, give the session to be more successful. Any thoughts, Dr. Sharp?
Well, I think when you really get down to what makes a session successful is you've got to have a moderator and a co-moderator who are, again, they have to be experts in the field. They have to be comfortable with public speaking, and I think they have to be able to guide discussion. They need to pick speakers who are also good speakers first and content experts second, to be quite frank. So that I think that and as you mentioned, the popular topics get better attendance. So I mean, just for example, diverticulitis fills the room every year. I wrote a proposal for diverticulitis a few years back, and it was very popular, and it was called diverticulitis. The problem's the same, but the answers are different every year.
Right. I mean, I guess, yeah, what's common is common, and I think that tends to interest people more.
But we try not to have I mean, we could develop a whole program on gallbladder, diverticulitis, colon cancer, and breast cancer, but that's not what we want to do.
No, but I think that kind of brings up the point again that your idea does not have to be earth-shattering and innovative and really new, right? Because I think sometimes the common topics like diverticulitis or, you know, appendicitis, things like that tend to interest people because you know, as a surgeon, you have to deal with those patients a lot more commonly than mentioned earlier, appendiceal carcinoma.
So Dr. Chai, international members would sometimes submit proposals on diseases or conditions that may be common or prevalent within their own countries or continents, but may not be that common, let's say, in North America. So it may not be, let's say, too specific for the clinical congress. Do you have any tips for the international members to make the proposal like broader for the clinical congress audience?
I mean, I think it's somehow if they can spin their topic to global application, meaning I think last year we had quite a few in our committee proposals regarding, you know, disease that's more prevalent in South America and Africa. And yes, we don't see those in US as commonly, but we do see some, right? We do learn about them in textbooks. So somehow if they can spin their proposal to include how we do it in our country or our continent and how we can spin it as a global application and what us in US can learn from their practice.
Yeah, I think we have to be careful about this because we do want an international representation. I will tell you that 15 to 20% of our attendees are international. Interestingly, last year in San Francisco, we had a much higher number than most other years. You know, it's closer. But I think if you get down to where you're terribly specific, you know, schistosomiasis might be just a little limited as far as some general attendance. I thought about this before we started talking today. So we have, for example, a Latin American Day. Well, the Latin American Day, which is 3 hours, is dedicated to what they want to talk about, and if they want to talk about a topic pertinent to South America that we don't see much here, and I guess Chagas disease or something like that. You know, that I think we have a spot for them. We don't
Mm.
have a Middle Eastern day or an Asian day or anything like that. So I think we have to be careful about getting too tight a niche.
I mean, and the other thing is, I think the other topic that we can discuss from international global standpoint is we did put on a session about gastric cancer management around the world. And then we had a speaker from Asia and Africa and India and US. And it was interesting because our treatment algorithm is definitely different depending on where you are, right? Like in Asia, they hardly ever do apparently neoadjuvant chemotherapy, regardless of staging. Whereas in US, it's pretty common to do neoadjuvant chemotherapy, you know, depending on stage. And the speakers from Africa and India talked about how they do screening. And so it was interesting to bring that all together. So if our international relations member can find a topic that they can kind of spin it and you know everyone from the world can apply, I think that would be interesting.
That's a very good point, Christy. Do you recommend or additional resources that authors can access to help writing proposals?
Well, I'll answer that. I think yes, but I think it's in general, it's your local situation, it's your committees that you're representing. And so if you have not written proposals, but you're interested, you need to be sponsored by a committee, an advisory council, a work group from, we don't take just proposals that I as an individual think I want to talk about. They have to come through a sponsoring committee of some sort. And all of those sponsoring committees, all those councils, work groups will have program committee subgroups. There will be program liaisons within many of them. And so almost always you've got a reference person in your area, in your committee, in your council, et cetera, who works with this on a yearly basis. And that's how I started. I was a program liaison from the Advisory Council on General Surgery. So I think that's, no, I don't have any printed references or articles on this.
Okay.
But from IRC standpoint, Jesse just reminded me that for International Relations Committee, you know, we're actually accepting proposals currently, and we'll be accepting them till February. So the earlier you get started on process, and I can tell you, you know, our members, a lot of our members do submit proposals, and we encourage everyone to do that because, again, I think it's a valuable opportunity to grow. But there are a lot of gaps, meaning, yes, they have a good proposal description, but taxonomy is missing. Objectives are missing. Co-sponsoring committees are missing. There are certain components. Proposal is where your idea is where it begins. But when you actually do the whole process, there are specific components that we also need to fill out. And Dr. Sharp shared some of those components in his slides. But it's hard to think about that the day before the deadline. This takes a lot of thought process. So again, for at least for International Relations Committee, we are accepting proposals right now. Please reach out to our staff. We have a lot of people who's done writing, got the proposals accepted, and we can help you brainstorm together. So let's not try to do it the day before the deadline.
That's excellent advice. I mean, there's very little we do in surgery that's best done the night before. I want to emphasize what you mentioned about co-sponsoring and so forth. And so that is something that we've not done. It's actually difficult to do. So, for example, one area where this always is a contentious area is thyroid, parathyroid issues, where we have general surgeons who do a lot of endocrine surgery, and we have head and neck surgeons who do thyroid and parathyroid surgery. And so we always want those to be co-sponsored to reduce the friction. But what that honestly and truly means, and is very rarely done, is that it means that if I am a general surgery endocrine surgeon and you, Christy, are ENT-based head and neck surgeon, and we both have a similar idea, or I know you, I can say, Christy, I want you to co-moderate a session that I'm writing on radio frequency ablation for thyroid cancer. And so you would need to talk to the general surgeon. I would need to talk to the otolaryngologists about how do we co-sponsor this. And this goes for all areas. You want to do a talk on mangled extremities.
Right.
You probably need your plastic surgeon. If you want a plastic surgeon to co-moderate, it's best to talk to them,
right,
so that they buy into the idea. The multidisciplinary sessions we think are really good. I've worked on this for a decade. It's hard to do because you may not, if you're an endocrine surgeon in general surgery, you may not know very many otolaryngologists who do a lot of endocrine surgery. It's very difficult to do the multidisciplinaries well, but they are extremely valuable because we'll get more attendees from a broader field. So we really think those are valuable.
Thank
Do
you.
you think non-clinical proposals are more difficult than clinical proposals? Do they get scrutinized more? Do they get is the process drastically different between the two in terms of vetting and selection?
We typically get so as I said, we get about 300 plus submissions, and generally about 80% of those will be clinical. So we do get a little bit fewer non-clinical proposals, but we actually look for the non-clinical proposals to fall into those categories that I outlined in my slides: education, equity, inclusion, education, etc. And so sometimes we might only, let's say, for example, we only had one ethics submission, and it really wasn't very well spelled out. We might not have an ethics session that year, but that could also work, under small bowel. We might not get a very good small bowel submission, and so it might not happen that year. So I think that we do scrutinize the non-clinicals, but again, they're not, I hate to say it, but they're not data-based, okay? I mean, they're often, expository, opinion-based, and some of them are extremely popular. I mean, we have a lot of surgical educators who come to Clinical Congress, and so they want to see, dealing with the difficult surgical resident, structuring a good surgical clerkship, etc. So I'm kind of a meandering answer, but non-clinical sessions are an important part of our Clinical Congress.
Dr. Chai, do you encourage young faculty members to write proposals? Do you think that will help them advance their careers, improve their networking abilities, etc.?
Yes, I definitely think so. I feel like I feel like putting proposal through International Relations Committee, talking to senior members, reaching out to staff. I think it really helped me network, get to know people more, and then non-IRC members to invite as a speakers. And then more you do it, just like Dr. Sharp mentioned, when we have these co-sponsoring sessions, when you're out there and you become a little more visible, they're more likely to reach out to you because, right, it's easier to reach out to people that they know the face or at least have an email address than if you're, in the dark. So it's definitely for junior faculty or junior surgeons. I think this is a great opportunity to start.
I think the other thing I would add here is that quality is better than quantity. There are certain sponsoring committees and groups who feel like if they send in 50 topics, they're going to get 10 or 20 topics, sessions approved. And that's just not true. I mean, you can send me 100 trauma topics. I'm not going to put 100 trauma sessions on Clinical Congress. So I think that there are groups who feel like quantity is the best way to go here. And let me tell you, the program committee hates that.
And I can also tell you from International Relations Committee, obviously we are both, Dr. Safadi and I are part of program committee. We screen the proposals. So you submit now does not mean that we're going to turn that into program committee as the final product. We have members who actually screen these proposals. So
Excellent.
just keep that in mind. Thank you.
Excellent. I think you mentioned earlier that you've submitted things that when you resubmitted them, they were accepted. And I might just give an example. Okay, so we're going to have about 5 breast panel sessions. And so you can imagine we probably get 10 pretty good breast proposals. And one thing we found over the years is that saying, well, Christie's proposal on breast cancer was really good, and Ken Sharp's proposal on breast cancer was really good. We're going to merge those. Well, that makes you unhappy and it makes me unhappy. So we typically would say, well, Ken, we're not going to take yours this year. Why don't you think about resubmitting this next year? We're taking Christie's. So the simple fact that your proposal is turned down doesn't mean that it's not appropriate, but you may well be. I remember last year we had 5 really outstanding abdominal wall reconstruction proposals. And I had complaints about, well, my session was really good. Why didn't you take it? So I had to explain, well, I had 5 really good proposals. So.
Yeah. So never give up. You can always try another year.
Oh, and also look for feedback. Look for feedback. Have somebody else look at it. This is something that, like I say, I deal with now. Why wasn't my session accepted? And I sometimes have to scratch my head pretty hard as to why that one didn't make it and this one did. But
great. Well, we've covered many topics. Hopefully, we've clarified the proposal process, and hopefully would encourage more surgeons to apply. Any concluding advice or remarks?
Our members should definitely give it a shot. Again, if it's not good, we'll help you. We'll brainstorm together. But again, half the battle is trying and writing that first proposal.
Yeah, I mean, again, it's just that issue of picking a good topic and writing a succinct and pointed proposal and explanation of your session. Why is this important? What if there's something new? If there's a treatment that has not been widely adopted yet, and who should be attending this? Okay, so if it's a breast cancer topic, it should be attended by surgical oncologists and general surgeons and rural surgeons and young surgeons. This is important to these groups. I mean, you might not spell that out specifically, but this is a broadly applicable topic for all general surgeons.
Great. Thank you very much, Dr. Sharp and Dr. Chai. I'm going to turn it back over to Jesse. You're in.
Thank you again, Dr. Sharp, Dr. Chai, and Dr. Safadi for taking your time to present this information. I just want to share some concluding announcements. So this webinar has been recorded and it will be on the ACS YouTube channel under the webinars for the Global Surgery Community playlist. So anyone during their proposal writing can come and view this webinar. Additionally, resident membership is currently free and will continue to be free in the 2025 to 2026 cycle. So those that are interested in attending Clinical Congress should certainly become a resident member at the college. And then lastly, if you had any questions about this session or need help with your Clinical Congress proposals, our contact information is up on the screen. And if you have any additional feedback, questions, or interest in what the IRC and the programs committee are doing, please reach out to any of these platforms. With that, once again, thank you all so much, and we hope you have a great day. Bye.
Thank you.
Bye. Thank you.